Thank you for joining us. We'll begin in just a moment. Thank you all for joining. We will begin in just a moment. We're still waiting for people to log on. All right, let's go ahead and get started. Welcome to Care and Choices at the End of Life, Hawaii's Our Care, Our Choice Act, a focus on general medicine. This webinar is available for continuing education. Next slide, please. And I do need to read this in order for this webinar to be accredited. So bear with me while I read the requirements for Care and Choices at the End of Life, an educational series on Hawaii's new Our Care, Our Choice Act. In support of improving patient care, this activity has been planned and implemented by Hawaii Pacific Health and Compassion and Choices, Hawaii American Nurses Association, and NASW Hawaii Chapter. Hawaii Pacific Health is jointly accredited by the Accreditation Council for Continuing Medical Education, the Accreditation Council for Pharmacy Education, and the American Nurses Credentialing Center to provide continuing education for the healthcare team. And we are so grateful for all of your partnerships. Hawaii Pacific Health designates this live webinar for a maximum of 1.5 AMA PRA Category 1 credits for physicians. Physicians should only claim credit commensurate with the extent of their participation in the activity. Hawaii Pacific Health designates this live webinar for 1.5 contact hours for nurses. Hawaii Pacific Health is accredited by the Accreditation Council for Pharmacy Education as a provider of continuing pharmacy education. This activity is accredited for 1.5 contact hours for attendance at the entire CE session. As a jointly accredited organization, Hawaii Pacific Health is approved to offer social work continuing education by the Association of Social Work Boards, approved continuing education program. Organizations, not individual courses, are approved under this program. State and provincial regulatory boards have the final authority to determine whether an individual course may be accepted for continuing education credit. Hawaii Pacific Health maintains responsibility for this course. Social workers completing this course receive 1.5 continuing education credits. Hawaii Pacific Health is accredited by the American Psychological Association and designates this live activity for 1.5 continuing education credits. Continuing education credits for psychologists are provided through the co-sponsorship of the American Psychological Association Office of Continuing Education in Psychology. Hawaii Pacific Health maintains responsibility for the content of the programs. In order to claim CE credit, please note that in order to receive credits for this offering, you must claim credit commensurate with the extent of your participation in the activity, complete and submit the evaluation survey that will be emailed to you within 1 week of the offering. Speakers cannot claim credit for their own presentations. Your CE certificate will be immediately available to you upon completion of your evaluation. All righty. Thank you to all of our partners. This is so exciting. Thank you all for being here today. If you have a question, you can ask a question at any time by typing your question into the question box, and we will get to as many questions as we can after the presentation at the end of the webinar. This presentation is being recorded, but don't worry, we can't see you, so you don't need to worry about what you look like. But please note that it is being recorded and will be available later. We are so honored to be joined today by the following speakers: Michelle Cantillo, RN, Advanced Care Planning Coordinator and Advanced Planning Coordinator with Hawaii Pacific Health; Dr. Chuck Miller, a physician specializing in hematology, medical oncology, and Program Director for Kaiser Hawaii's Aid and Dying Program; Dr. Brian Goodyear, a clinical psychologist, Jake Blechta, a pharmacist with ElixRX, and our special guest today, who we are very honored to be joined by, Laura Arcibal with the Department of Health. She specializes in Hawaii State Telehealth and Healthcare Access Coordinator. That's her official title, and she also specializes in it. Compassion and Choices improves care, expands options, and empowers everyone to chart their end-of-life journey. We are the oldest, largest nonprofit organization in the country dedicated to empowering everyone to chart their end-of-life journey. So who do we have with us here today? We're going to launch a poll to find out who is joining us. If you can mark who you are, a registered nurse, APRN, you can choose more than one if you're an overachiever and have a lot of degrees. All righty, let's go ahead and show the results. Wonderful. It looks like we have a wide range of professions represented here today and a lot of registered nurses. Our learning objectives. Today, we will be reviewing the clinical competencies for participating in medical aid in dying and requirements of the law. We're going to be examining the role of nurses, APRNs, physicians, and mental health professionals in supporting patients in medical aid in dying. Examine the team-based approach to patient-centered and directed care. Provide an update on the Our Care, Our Choice Act. And examine the roles of pharmacists, experiences, and issues in relation to medical aid in dying medications. So where do we start? I'm going to hand it off to Dr. Miller to talk about the first patient request. Dr. Miller. Oh, Dr. Miller, I think you're on mute. There we go.
How about now?
You're great. Thanks, Dr. Miller.
Okay. So, good afternoon, everyone, and I want to thank Compassion and Choices for giving me the opportunity to do this presentation. The experience that we've had so far in the 2 years plus that the Act has been available, the setting for the first patient request usually goes to either the primary care physician or the specialty physician who is caring for the patient's terminal disease. So that can be the oncologist, rarely a psychiatrist, but neurologist, pulmonologist, or cardiologist. The questions are usually not so much a question, but doc, I want to use medical aid in dying. And we can talk about it later, but usually most of the patients have done some research and education on their own so that they understand at least the basics of our law. But you will get unexpected responses, i.e., I want the drug tomorrow. Well, that's not going to happen. We'll go over all the details later, but there is a 20-day waiting period between the first and second verbal request. And one of the things that I have found important when I first see the patient is, are they going to make that 20-day waiting period or not? And we'll talk a little more about that later, and see if there's any actual physical barriers to self-administration. And by that, specifically with patients who have head and neck cancers, are they going to be able to swallow? If they can't swallow, we have to look at either a feeding tube, PEG tube, or we can also give the drugs rectally. Next slide. So how do you, as a provider, respond to this request? Well, yes, you have to educate yourself. You have to know the ins and outs of the law. What are your personal beliefs? Well, my feeling is that everybody who is attending this webinar today wouldn't be here if they didn't have personal beliefs that they believe in providing aid in dying. The next thing is 3 times listen. Just listen and listen and listen. When I first talk to the patient, I will ask them how they're doing today. And sometimes nothing comes out, but that's the point when the patient's concerns, their fears, their wishes, all of these things can come out with that first opening question. And the bottom line, and we'll talk about the family. We've never had a case where family, the patient is not notified some next of kin. The other thing is, if you don't want to do this, that's fine, and that's totally your decision. But then, if a patient asks you for aid in dying, I believe it is incumbent on you, ethically and morally, to refer that patient to a provider who is willing to participate in the law. Next slide. So let's talk about medical aid in dying. It's a totally and completely recognized medical practice. It has published standards of care and clinical practice guidelines, where a mentally capable adult with a prognosis of 6 months or less to live can request a doctor's prescription for medication that they can self-ingest to end terminal suffering. Next slide. So in our law, the patient has to be over 18, has to be a resident of the state of Hawaii, which is pretty easy to do. Has to be terminally ill, and this is the next step where some providers, physicians and other, prognosis of 6 months or less. There's, I've had 40 years experience taking care of cancer patients, and so for me, it is not a difficult choice and not a difficult decision or evaluation to say, yeah, you're not going to live 6 months. But it's art less than more than science. And the first patient I gave a prescription to lived 18 months. And that's perfectly fine. There's nothing, it's our judgment. Mentally capable of making informed decisions, and Dr. Goodyear will talk about this in much more depth, and able to self-ingest. So if they can't swallow, they have to be able to shoot the medication into the PEG tube with their own hand, or into the rectal tube with their own hand. That's still considered self-ingestion. Next slide. Okay, the law requires us as providers to talk about other options besides aid in dying. They're all fairly straightforward. VSED, just a comment, it's legal in every state in the union. I would never recommend it because it takes patients from 4 to 8 days to die. Continuous deep sedation used to be called terminal sedation, and it requires the patient being in an inpatient setting where they're getting intravenous morphine or other suppressant drugs to basically put them to sleep to end their terminal suffering. And hospice is what most patients, almost every patient is on when they actually do take the drugs for aid in dying. Next slide. So the law provides 3 different providers. I think right now the current law says you have to be a physician or a psychologist to serve in these roles. So the prescribing physician, the prescribing provider is called the attending by the law. That job, his job, her job is to evaluate the patient, make the appropriate documentation, follow each step in the requirements of the law, being compliant with it, and then prescribe the medication after meeting all those requirements. And the patient also has to be seen by a consulting physician, and we'll talk more about that. Right now, APRNs cannot serve in either of those roles. And I'm going to let Sam talk about, we have pending legislation to see if we can change that so that advanced practice registered nurses can serve as either the attending or consulting provider. Next slide. Sam, if you want to jump in.
Yeah, thank you. Thank you, Dr. Miller. We have some really important legislation at the Hawaii State Legislature right now. This legislation was inspired by a recommendation by the Department of Health when they realized that there are just insurmountable barriers for some patients to access medical aid in dying, especially if you live on a neighbor island. And, you know, this option should be for everyone who's eligible, not just people who live in Honolulu. And so the legislation would remove the barrier that actually prevents qualified advanced practice registered nurses from acting as the attending, consulting, and mental health provider for patients seeking medical aid in dying. It would also allow the prescribing provider the ability to expedite the mandatory minimum waiting period so that patients are able to access it if they're unlikely to survive that 20-day period. So if you're interested, we need all the testimony and help we can get. A lot of legislators still don't understand what qualifications advanced practice registered nurses have. They're so highly qualified. So if you're interested in it, let us know and we can send you more information. But now it's time for another poll question. So poll, please. The patient makes their first oral request to their primary care physician in order to proceed with medical aid in dying. True or false? Really think about that question. They make their first oral request to their primary care physician. All right, let's show the results, please. Well, for those of you who said false, you are correct. Well, that could be the route that the patient takes. They don't have to make their first request specifically to their primary care physician. So primary care physicians can absolutely participate in the law. They can act as the attending or consulting provider. However, there are other physicians who can participate as well, and hopefully soon qualified advanced practice registered nurses as well. So the patient does need to make 2 oral requests separated by at least 20 days right now. Not necessarily in person. This can be done via telehealth. But they do need to show their voluntariness of the request. And 1 written request signed by 2 different witnesses, again, to show that there's no coercion or abuse. And in over 20 years of medical aid in dying being authorized across the country, there's never been a single incident of coercion or abuse. All right, now I'm going to hand it over to Michelle Cantillo, who's going to talk about the nurse's role.
Hi, good morning, everybody. Thanks for having me here. So just to know my role for Hawaii Pacific Health, I'm the Advanced Care Planning Coordinator. And so I do a lot of patient education as well as staff education about end of life, palliative care, advanced care planning upstream. And medical aid in dying is one of those end of life decisions, which is very important. And we should be able to support our patients and our staff and our providers who are helping to participate in this law. So my role is really a lot of education When patients access as a nurse over to an APRN, to a social work, I always tell the staff, be prepared, get the education that you need. Go on the Department of Health website, know who your resources are, learn the law, learn the processes. And within your organization or your clinic, who are the people who are supportive of this law? Because not everybody is, but know who your resources are and use them and work together with them. Your resources also are not only within your organization, it's outside your organization with Compassion and Choices, with hospices, the team. So build that team as you move forward to help and support your patients. Once a patient also has determined they want to move forward with this law, it's a very important, as Dr. Miller had said, is to really see who's going to really support that patient. And as the poll had described, it's not necessarily the patient's primary care physician if they choose to opt out. So then then figure out, is it the oncologist? Is it the pulmonologist? Is it not a neurologist? So work with the patient's specialty. A medical aid in dying, or I get the referral from a social worker or oncology nurse navigator. It's important to explore the patient's requests. Have an education with the patient. And as Dr. Miller, please invite the family. Well, it may not be the family. It may be their support person or persons. I've done many Zoom meetings with them just to get to know who they are, really talk about their goals of care conversations, know what's their understanding about their medical condition, their prognosis, know who they are, who's this person before they got this disease and this prognosis. What are their goals? What are their wishes? Also, I also look at their barriers. What's their struggles? And I let them do homework. Sometimes one patient had said to me, Michelle, I really haven't told my niece about this, but she's very important to me. And then I explore with them, why not? If I don't want people to hide things from their family, especially if this is a close-knit family. So I really go in-depth conversations with them. Part of it also is doing their advanced care planning, making sure their forms and things like that are in order, and especially start having that hospice conversation. So reviewing all end-of-life options with the patient, as Dr. Miller had said in the previous slides before. Next slide. Our role as nurses, we are our patient advocate. We be objective. Dr. Miller said, know where you stand regarding this law, and then make sure that when you also convey it to your patients and families, make sure, or their support people, be sure you're there for non-judgmental support, not only to the patients, but also to physicians as well. Because sometimes what happens with me in my role is that a physician will come to me and say, Michelle, my patient asked me, but I'm not quite sure if I'm ready to do this. So again, my opportunities provide them the education and say, that's totally okay. Let's see how we can support the patient and see who within our little group, your resources, as I mentioned before, can also help support that patient and the physician as needed. So again, provide that information with a neutral manner. My role, again, for those physicians who are kind of sitting on a fence about, well, I'm not sure if I want to help or not. Maybe I can be the consultant for this time and then do the attending next time. And that's where my part is also to walk them through those steps. My role as a nurses or the nurse navigator roles, even the APRN that works with the providers and the social workers, they're awesome. They do a wonderful job of I'm on the back end, and they're right up there making sure the appointments are done, the referrals for psychology or for the mental health consultant is done. Reminder to the providers, hey doc, you need to complete the Department of Health forms for the attending forms. Once the prescription is done, follow-up forms is needed. making sure the telehealth is done, because with technology and telehealth, not all our patients are quite savvy about that. So that role also, I need the staff as well. Dr. Miller already explained about patient's condition and timeline, very important. If we have to fast forward this process, how can we help support and make sure those referrals are get quickly on time? So once we have referrals, our providers, they know, hey, this has got to be less than 2 weeks. We got to make sure this happens within that 20-day window. I mentioned already, but hospice education, I can't thank the hospice, all the hospices. It doesn't matter if they're the bedside or not, they're awesome. They're such a valuable resource to the patients and their families for medical aid in dying. As Dr. Miller said, all of our patients have gone through this process, 100% have been hospice enrolled. They have our phone numbers, they have our emails, they have whatever connection is needed, whatever questions they have, and they like that. They know, oh gosh, I can call my oncology navigator, you know what, Kalimomi or Straub or my social worker. They'll know they have a connection. Michelle, I need help regarding this. Give them that connection. They love to have that support, because you know what, sometimes they feel alone in this process. Same thing with our providers. Make sure you're there for them. Again, patient advocate. Next slide, please. Many of our referrals may come direct. Most of it, I would say 75 to 80% comes from a physician. And then requesting the referral goes out to a nurse navigator or social worker. However, there may be times when, as an inpatient, it may come to a nurse and then it goes to palliative care to do the discussion. Or a patient may come to our social worker, nurse navigator, and say, you know what, I'm interested in the law. Be prepared again. Again, goals, like I mentioned, the education, I kind of covered this already, the goals of care discussion, the advanced care planning, get that upstream. Our providers, once they want the process to start rolling. So by the time they see that patient for their first telehealth, first oral request, we've done their advanced care planning, we've done their goals of care. They know the patients. The patient has some education about what the law is. And also, if they want to proceed or not. I had recently, a pulmonologist said, hey, this patient was interested. So I did have a meeting with him and his wife, did their ACP. And then after much education, he said, you know what, Michelle, I don't think I'm quite ready for this, but I'm gonna keep it at the back of my mind for maybe a year or so, because he's on home O2 with oxygen, pretty mobile, but he's done the education. So I commend him for starting early. One of my processes too, and the nurse navigators, is to also help do the medication education about the compounded medical aid in dying drugs that Jake will talk about later. But we start the introduction, because that's the first question. There's like, how am I gonna get, how is this really done? So make sure you know about what the medications are. And then formalize. Once you finish your education with your patient, I always say, okay, what's our next step? What's our homework that you have to do? I'll tell the patient, you know, you have to homework with your family, you have to complete the advance directive, work with the pulse with your doctor. On our end, we have to get you attending. We got to make sure the referral is done. So make sure those steps are done in order, so they know and we know what our next steps are. And again, who are the attending and consulting providers. Next slide, please. Again, my role, it could be a nurse navigator, a nurse facilitator, a social worker. Our social workers for the oncology team are awesome. They get right involved. They're basically the navigators through this process, honestly. They do everything up front. They do the coordination, they help with the referrals. They also do their psychosocial assessment, etc. Another thing they do is they will check for the insurance coverage for the prescription for the drug, and also the simple part of they'll have all the FedEx packages all ready, because what we do, we FedEx our prescription right away, because we don't want it sitting in the slow mail, which happened with one of our Maui patients, was a slow mail before it got to FedEx. So it took another 24 to 48 hours before the patient actually received the drug. So education is like, get FedEx, get it fast, quick, So patients, especially those on outer island, can get their medication within 24 hours. Next slide. And back to Dr. Miller. Thank you.
Thank you, Michelle. So the first oral request, what I as an attending physician have to do, diagnosis, prognosis. Diagnosis is obvious. It's from the medical record that terminal disease, a terminal diagnosis. Prognosis, again, just to expand on that, it's easy for me to evaluate the prognosis for an oncology patient because I've had years of experience with them. However, if I get a referral for a neurology patient or a pulmonary patient or a cardiac patient, I will many times talk to the referring specialist and say, okay, you believe, the assumption is that they wouldn't send this patient if they didn't believe that prognosis was 6 months or less. But sometimes I want to and need to just do a recheck with them. And we've certainly had plenty of cases from those three specialties where I depend on their evaluation for the 6-month prognosis. Mental capacity, Dr. Goodyear is going to talk extensively about this later in the program, but honestly, in my experience in these 2 years plus, it's not rocket science. It's very obvious if the patient has the mental capacity to make this sort of medical decision. It's most of the time they are very clear-thoughted. They have read and they have a lot of education about the law, and they know what they need to know about it. The voluntariness, we've never had a problem with any sort of even a hint of any sort of patient coercion. And we talked earlier about the self-administration, adult and a resident. Next slide. So the consulting physician is a required review by the law, and basically they're only doing one thing when they evaluate the patient. They're saying, yes, I agree with Dr. Miller's clinical assessment that this patient meets all of the requirements for the law, the medical aid in dying law. And then Hawaii always has to be a little different. We are the only state that requires a third evaluation from either a psychiatrist, psychologist, or a licensed clinical social worker. And this is to do that evaluation of mental capacity to make this medical decision. And I think Brian will talk to you later. It's very obvious. It is not subtle, but we'll talk about that later. Next slide. So let's talk a little bit about the provider's responsibilities. First of all, no one has any duty to participate. If you don't believe in aid in dying, fine, don't do it. There is no liability on the basis of our law. There's no liability if any of the team members act in good faith under the act and follow all of the requirements. And they're not that difficult. And not just here in Hawaii, but there's none of the 10 jurisdictions who have legalized aid in dying have ever had disciplinary action taken against a provider for either declining to participate or to participate in aid and dying. Next slide. This is written into, I think, every single law in every jurisdiction, that the law taking aid and dying cannot change the status of the patient's health insurance or life insurance or any other legal or medical contracts. And most importantly, it defines very specifically that medical aid and dying does not constitute suicide, mercy killing, homicide, or anything like that. Next slide. So this is more of the requirements in the law. The patient has to make 2 oral requests to the attending physician. The attending physician is the guy or the girl who is going to be writing the prescription. And those 2 oral requests cannot be less than 20 days apart. They don't have to be done in person. Most of the time, the second oral request I've done by telephone. And in those 20 days, the patient has to have an evaluation by a consulting physician, an evaluation by a mental health provider, and also has to do a written request, and that has to be witnessed. The signature has to be witnessed by 2 witnesses, and one of whom can't be related to the patient. And somebody taking care of that, a member of the healthcare team who is taking care of the patient cannot be a witness. The important thing about the written request, which is in the law, which is kind of a dumb thing, but the written request cannot be dated until after the patient has been seen by both the consulting physician and the mental health provider. Next slide. So they wanted us to tell a story, and Brian and I told you that the mental capacity is pretty straightforward, and the data at the end of the talk will show you about how many people have not met the requirement. But I'll talk about a patient that I saw in Hilo who was a retired psychiatric nurse in a hospice setting, whose son has said, you know, she's wanted to do aid and dying for years. And by the time I got to see her, her mental capacity was borderline. And I'm a softie most of the time. And when I went directly into her face and looked into her eyes and said, this is whoever, do you want to have aid in dying to end your life? She would look at me and she would say, yes. But maybe 2 minutes later, she'd be off in cloud 9. So I said, okay, I can kind of sell this as competency. But when Dr. Goodyear saw her, and Brian, I'll let you go ahead and tell the rest of that story. Brian?
Thanks, Chuck. Yes, I got to see this patient, I think it was about 10 days after Dr. Miller had seen her. And there had been quite a significant decline in her cognitive functioning by that time. She was living in a care home in Hilo, and I flew to Hilo to see her. And she was largely bedridden, so she was just lying in her bed. Her son was there with her. She was alert, but she was not fully oriented by any means. And her thought process was not coherent. And her responses to my questions tended to be tangential at best or completely irrelevant in some cases. And she was unable to provide coherent answers to the questions that I usually put to patients about their mental capacity. So unfortunately, I had to say, no, this patient does not have the mental capacity. Her son was very disappointed. He wanted to help his mother to go through this process, but unfortunately, I had to tell him that I just can't confirm that this patient has the mental capacity. I do want to emphasize that this patient was the exception rather than the rule. As Dr. Miller was saying, most of the patients that we see are clearly mentally competent, and there's no doubt about that. But this was one exception to that rule. Okay, next slide, please. A little bit more detail about the mental health evaluation. And let me just say that I'm going to cover this relatively briefly. On February 24th, we will be doing another webinar which will focus more directly on the mental health issues related to medical aid in dying. So as Dr. Miller had already indicated, according to the Hawaii law, all patients who request medical aid in dying must be referred by the attending physician for what the law describes as counseling. And counseling is defined as one or more consultations with a licensed psychiatrist, psychologist, or clinical social worker. And the evaluation by a counselor determines that the patient is capable, that is, that the patient has the mental capacity to make an informed medical decision, and also that the patient does not appear to be suffering from undertreatment or non-treatment of depression or other conditions which may interfere with the patient's ability to make an informed decision. Just briefly, I'll say that that has not been a significant issue in almost all of the cases that I have seen. I had a few patients that have had some history of depression and a couple of patients that were actively being treated at the time they requested medical aid in dying. And I did recommend that they continue with mental health treatment, but I did not feel in either case that their mental health condition prevented them from making an informed medical decision. Next slide, please. And the components of the mental health evaluation, what I do, I typically will get a referral from Susan or Jody, one of the two patient navigators at Kaiser, and they'll send me relevant medical records, which I'll review. Sometimes there are mental health records available. Typically, the patient has no mental health history, so that's not a big issue in most cases. I'll do a clinical interview with the patient. We used to do them in person. Most of the visits were at the patient's home. But since COVID, most of them have been done by telehealth. which we can talk more about later. After completing that, there's a Department of Health form that I have to complete and send in to the attending physician, and of course, write up a detailed clinical report for my own file and also to go to the attending physician. Okay, that's it for me. I'll hand it back.
This slide is one that I'm not sure it's in the right position, but this is a true statement. Most of our patients want to have some, not necessarily just the hospice nurse, but someone with medical expertise, with medical understanding when they are actually in the process and going to take the drugs. My personal experience is two different things. Number one, I always offer to the patients I see, if they want me to be there when they take the drugs, I'm happy to do that. And I've been attended at 7 different deaths. But there's also a small number of patients who don't want anybody outside of the family there, not even the hospice nurses. And this is a purely personal choice by the patient if they want outsiders in there. And my experience, our experience has been that sometimes the culture of certain Asian populations don't want outsiders there at the time of the death. But that's just food for thought information. Go ahead, Sam, back to you.
Thank you so much, Dr. Miller and Dr. Goodyear. I will say just on that note, Dr. Miller, I think a lot of people don't realize, when your loved one is about to take the medication, it can be so helpful to have somebody else there. If you're able to, so that you can focus totally on your loved one and not worry about the medication or anything like that. But of course it's up to the patient. So, all right, we have another poll question, and I apologize. It looks like some of you are having technical difficulties answering the polls. So hopefully this will work for everybody. Can you go ahead and launch that poll? So the question is, I think this is the last poll. There we go. Medical aid in dying prescriptions are given to the patient after the requirements of the Our Care, Our Choice Act have been completed. True or false? Let me read it again and really listen to the question. Medical aid in dying prescriptions are given to the patient after the requirements of the Our Care, Our Choice Act have been completed. True or false? And if you're having technical difficulties and you can't vote, you can still get CEs for this or CMEs for this webinar. But the best way to learn is to vote. And when you're wrong, that's like the really, really best way to learn. All righty, let's show those results. Oh, well, the majority of you are wrong, which is great. That means you're going to learn. You're going to remember this answer. Next slide. Oh, I guess share the results. Can everybody see that? Next slide. So the prescription is not given to the patient. The prescription is mailed, faxed, e-delivered, or hand-delivered to the compounding pharmacy. Now, it may not always be a compounding pharmacy, but right now, the medication most commonly prescribed necessitates a compounding pharmacy. So again, you don't give the prescription to the patient, it goes to the compounding pharmacy. And if you're having trouble finding a pharmacy, you can always reach out to us. We do keep a list of pharmacies, and chances are we may refer you to Jake Blechta at ElixRX, who's going to speak next about the pharmacy component Over to you, Jake.
Hello. Okay, so D-DMA, that's the current
Jake,
recommended medication. Can
we
you hear me?
lost you for a second.
Yeah.
Can you start over? It seems
Yeah,
to work
can you hear me?
now. Yeah.
Okay, all right. So the medications in the D-DMA, which are the current prescription that's being prescribed, is digoxin. It's 100 milligrams of digoxin, 1 gram of diazepam, 15 grams of morphine, and 8 grams of amitriptyline. The older version was DDMP, and the amitriptyline, and that was replaced with, or amitriptyline replaced propranolol. Besides that, they'll also get 2 vials with antiemetics in it. So it'll be either haloperidol or Zofran and Reglan. So 2 different bottles with the different antiemetics for nausea. Before they go ahead and anything hours ahead of time, so they need to take it on an empty stomach. When they're ready to take it, they'll ingest the 2 antiemetics at the same time, and then they wait. There's 2 different ways to do it. There's either taking the bottles separately, the digoxin separately from the rest of the medications, or else they can take it all together. The way when they separate it, they're going to take the antiemetics and then wait 30 minutes, and then they'll take the bottle with digoxin in it. They'll mix the digoxin will come in a 2-ounce plastic vial by itself. It's just a very small amount of powder in there. So they'll mix in any kind of liquid, clear, water or clear juice, anything like that. They shake it up and ingest that, and then they'll wait another 30 minutes. And the second bottle is a 4-ounce glass bottle that contains the diazepam, morphine, and amitriptyline. And they'll add in whatever liquid they're going to use. They'll add that, and they can add it directly to the bottle, or they can dump the bottle out into a bowl or a cup or something and mix it in there if it's easier. And they'll ingest that. And that's supposed to be taken within about 2 minutes time. They should have finished ingesting that. Alternatively to that, they can also do it all at once. So they can take the antiemetics, and then depending if the doctor wants them to do it like this, they can add all the powders to one mixture, the digoxin plus the other 3, and they can take it all at one time. And that would be about 45 minutes to an hour after the antiemetics. Okay. Let's see. So next slide. I think maybe we should go, yeah. All right, so my involvement, usually the pharmacist's involvement, usually before the prescription's sent in to us, we often get in contact with the doctor, and they tell us that a prescription is going to be coming. So we're just aware that it's going to be coming, make sure we have the ingredients that we need. And if they want, they can fax us the prescription ahead of time, so we're ready and we can actually type it up and get it all set for the patient, so we can minimize the time it takes once we receive the prescription. During that time of waiting for the prescription, we can contact the patient or whoever's listed as the contact for the patient, and we'll just ask them if they have any questions about the medication or the process, and clear anything up that they may have questions about. Then once, we'll also set up either when they want to pick it up, or else if they want us to mail it to them. We do mail either with just a USPS or FedEx to the outer islands, or even on Oahu, it's fine. And then so we'll set up the pickup or the mailing, and then we'll wait for the prescription to come in, and we'll compound the medication, which basically is mixing the raw powders. Since these medications aren't available manufactured, we can mix them, and that's what basically compounding is. Before we send it out to the patient, we usually, or have them pick it up, we usually contact them again, make sure they don't have any questions. We do have a packet we can give them, but most of the patients are actually pretty well versed in it. They don't usually have many questions about it at all. We just make sure there's, if there's anything to clear up, we can do it then. Then we dispense the medications, either by mail or in person. And there's actually no forms for us to submit as a pharmacy. We just do the normal signatures and whatever we need to do for the dispensing of prescription. And next. Okay, so the main red flags for dispensing this, and they can be caught by the pharmacy or the prescribing doctor. So anything having to do with absorption issues. So like GI malignancy, swallowing concerns, gastroparesis, cachexia, bowel obstruction, tensitis, pretty much anything that can, compromise the absorption of the med. Cardiovascular wellness. So in younger patients with Chuck?
Just a comment about that. The average time for falling asleep from the ingestion to the average immediate is about 15 minutes. And the average time from ingestion to death in our patients has been 2 hours. But the point that I try and always make with the families is that this is incredibly variable. Each patient's metabolism of these drugs is going to be quite variable. I've had one patient fall asleep in 5 minutes and she was dead in 30 minutes. I've had at least 3 patients take over 3 hours, a couple of patients over 4 hours, and we had one patient who took over 6 hours. He met these requirements, the red flags. He was obese. He was a very large Samoan guy, very young. He was like 50 and totally healthy except for his cancer, which was terminal. So that's just something to be aware of. These red flags need to be looked at.
Thank you. Yes. So another one going along with that is cardiovascular wellness. So for instance, younger patients with ALS may be very, have very healthy cardiovascular system. So it may take longer. You should be aware of that. And obesity over 300 pounds is a red flag. Alcoholism and tolerance to opioids or benzodiazepines. Next.
Thank you so much, Jake. And thank you, Dr. Miller. Next, I'm very excited to have us all hear from Laura Arcibal with an update from the Department of Health. Laura.
Aloha, everyone. Hope you are all well. Mahalo to the speakers and the providers, and for all of you joining here. I really appreciate this opportunity, and also to Compassion and Choices, Sam, Karen, and Christina for helping patients and providers access the law. My role in the department is to serve as staff to the Our Care, Our Choice board. I'm also the point of contact in the Department of Health and have been involved since prior to implementation of the law. The department's role is now, since after implementation, is to really collect the data and report to the legislature annually. We collect data on qualified patients who received the prescription. And so first I'm going to touch upon the forms and tools that were created. These were vetted by the board and approved. And then I'll go ahead and provide updates on the data that's been collected and share some thoughts on it as well. So these tools are very helpful. We're going to start first with the attending provider form. And it covers the main sections of the law, the oral requests, as well as the waiting period, and then going into the writing of the prescription and what happens during those times. So the attending provider really serves to cinch all of these forms and is responsible for sending it to the department as well. So next. Okay, attending physician report. So there are forms on the Department of Health's website. These are actually required. I'm not a medical person per se. I don't make any judgment. And so these forms, the board, recognized very early on that it collects specific data, specific information that makes sure patients are meet the requirements of the law. So there's the attending physician reporting form. There's also the consulting physician form, as well as the counseling providers form. the patient's final attestation form, as well as the follow-up form. The follow-up form occurs once the attending provider is informed of the patient's death, and the attending provider submits that form. You can go forward. Okay. So this part of the form is really important to making sure that the diagnoses and the prognosis is captured, has a patient's name, and go forward, Sam. And then also the oral request information and the date that the oral request was made. I think this is important because there are patients out there that may have a primary care provider that chooses not to participate. So capturing this information is really important for the provider that's going to be participating in the law. And that information is collected there on the form. The consulting physician form. Yep, all of those. Okay, great. Thanks, Sam. So for the telehealth update, you can go forward.
We actually have another poll question. Thank you, Laura. So we'll pause for a second. And the telehealth question is, the poll question is, telehealth can be used as a method of communication between provider and patient for any of the components of the OCOCA, true or false? You can vote now. All righty, let's go ahead and show the results. Well done, everyone. We finally have a majority in the, you got it right. So hopefully you'll remember it. True, within provider scope, same as face-to-face and documented, according to Hawaii statutes, you can use telehealth for any of the components for Our Care, Our Choice Act. And I'll hand it back over to Laura now to talk more about that.
Okay, yes, I think providers are like experts now on telehealth. Prior to COVID, we really didn't have that many providers doing telehealth. So I think that's one upside in terms of COVID. What I wanted to share is that there is support in the department and as well as the state to make permanent some of the current telehealth waivers and mandates that came through on the governor's executive orders. And so we anticipate the majority of the telehealth waivers to continue even post-COVID, and we're looking to make those permanent. So we have yet to see, what those are, but we're hoping that we'll adopt all the measures that occurred. And so, for example, what would be applicable to this group is connecting patients to their homes in both rural and non-rural areas, and establishing new patients, particularly for those that provide mental health services. COVID highlighted patients who do not have broadband access. And so we're looking to establish the telehealth console this year to help address some of those gaps, broadband, language barriers, and also the use of digital tools, because we do recognize that there are folks in the community that aren't familiar with utilizing the internet or utilizing apps. And I heard Michelle earlier, oftentimes the navigators are helping patients just get connected online. So there is a push to help educate the community and help folks to get up to speed. So we do anticipate expanded coverage for Medicare, Medicaid, and private payers. And there's also a broadband Hui that has been working together, meeting regularly every Wednesday to talk about broadband access in the States, all the pukas in the area in terms of the neighbor islands, and looking at affordability as well as reliability. in Hawaii. And so we're hoping to get some funding soon. We do have support for that. There is a push to establish a broadband office in the Department of Business and Economic Development. And so we look forward for that. So that's the update for telehealth.
Thanks so much, Laura. Now let's hear from either Dr. Goodyear or Dr. Miller, whoever unmutes first, a story about your experience using telehealth. And while they're unmuting themselves, I just want to remind everyone that you can ask a question at any time using the Q&A box on your screen, and we'll get to as many questions as we can shortly. All right, go ahead. I think Dr. Goodyear, do you want to go ahead and share a story?
Thanks, Sam. Rather than just one story, I'll just comment about the switch. Prior to COVID, we were doing the vast majority of mental health evaluations in person. Most of them were done at the patient's home. And I think in many ways that is the most preferable way of doing them. It just gives you a kind of a better sense of the patient and what's going on, not just with the patient, but with the family as well. But after COVID, we had to switch over to doing almost everything by telehealth. And I was a little bit wary about doing that at first, but I've been surprised that it's actually turned out very well. And there have been no significant problems doing the evaluations by telehealth. And it's certainly in some ways more convenient for the provider. You can do it from your home or your office without having to travel. And perhaps for some patients, they prefer to do that rather than having the provider come into the home. But on balance, I still prefer to do it in person. And I'm looking forward to being able to do that again when the COVID restrictions are reduced. Chuck, you have anything to add?
I agree totally with Brian's the concept of doing the home visit is just personally for me and for the patients we did this, it's very, very important for them. It makes them, you get to touch the patient, you get to sit by their side. But COVID changed all that. So basically, I've had no issues at all with doing the attending physicians' evaluations by either telephone or telehealth. I think it is important that for many of these patients, it's a great benefit. And that's because a lot of them are really sick, and to get even to the clinic for an evaluation, for to do the requirements is a challenge. And so from that respect, I think it should be maintained as an option for any patient who requests it. I've started, since I got both of my COVID vaccines finished a couple of weeks ago, I've started going back and seeing patients in their home over the past 2 weeks. And I have to say that I'm very happy to be doing that. So telehealth, it's important, it works. It's just not very satisfying to providers.
Thank you, Dr. Miller. And we're slowly starting to run out of time, so we're going to skip the next two poll questions. And I just want to add that, Dr. Miller and Dr. Goodyear, you both are so wonderful. And if it were me, I would love to have you come to my home. But just to let everybody, just a reminder that you don't have to go to the patient's home to support them, but if you can and the patient welcomes it, it's a wonderful thing. So now let's go to some numbers. Back to you, Laura.
Okay, thanks, Sam. I thought I'd provide a summary of 2019 and 2020. It's pretty self-explanatory here. There may be one edit that I'll make. It's actually 67 qualified patients. We collect data again on qualified patients who received a prescription. So there may be more numbers that are being collected within the various organizations. 41 ingested, and then the average number of days from first oral prescription to from first oral request to a prescription is here as well, 35 days, and we went up a little bit in 2020. And it could be because we do have more providers participating in the law. There may be other reasons for that slight increase. The most cited underlying illness is cancer, some form of cancer. And the majority of patients are over the age of 65, have private insurance, white, and they're male. Your next slide. This is a table on the number of providers that have participated in the law and patients have successfully received their prescription. So you will note here that Kauai has no attending providers that we have on record. So access is still quite limited overall on the neighbor islands. And Oahu has basically the most providers that are involved in the in patient access. And that's what we have. So our recommendation is still going to remain the same in terms of recommending APRNs to serve as any one of the three providers for patients to access the law. Prior to COVID, access was already limited, and we knew that. And there is a shortage statewide and as well as nationwide. So having the APRNs participate will help patients be able to access the law. And just a few comments in terms of what we're seeing. The Department of Health, although the law requires that the attending provider requests for the final attestation, we do not need a copy of that. That record is kept in the provider's record. Be sure to collect all the forms, which is the attending provider's role, to collect the counseling provider form, the consulting form. That's considered report number 1. So all the forms get submitted together as opposed to piecemeal. And then report number 2 would be just the follow-up form. Just another reminder to indicate the underlying illness on the death certificate. And this is according to the law. And then I'm going to continue to encourage engagement, networking amongst providers, and training to increase access and awareness about the process. The forms are accessible online, and I'm always available to answer any questions as well. And our recommendations remain the same. So these are the recommendations that we made on the 2019 legislative report. This is going to also remain the same on the 2020 report, which is due July 1, but I'll be finishing up that report before that, most likely in March or end of this month. Okay, thank you.
Thanks,
Hi.
Laura. Now over to you, Michelle.
Okay, I'm just going to quickly run through our data. The 55 patients that we had were interested in medical aid in dying, whether it's just an inquiry and they proceeded. As you can see, yes, the majority is cancer, but also we've had some elderly patients, and not in the 60s with failure to thrive. We've had some pulmonary fibrosis patients, and most recently 2 ALS patients and 1 cardiomyopathy patient. Outer Islands, even though, because we support Wilcox Medical Center, so a lot of our referrals are coming from Kauai. And yes, it's correct in saying that very limited in terms of attending physicians. So a lot of our Oahu physicians have supported our Kauai patients. And you can see Maui and Lanai, our oncologists do support Maui, so they go over there as well. one of our process, we do encourage palliative care consult. I know our hospices have some palliative care excellent providers, but we also have an outpatient palliative care that it's optional for patients, and encourage the early discussion with hospice. Next slide. So our breakdown, basically 32 patients after education and all the process that you've heard about before have completed their first OVA request. We did have 5 patients who died before their second OVA request, 15.6%. So that's why the legislation to waive that, and made the decision up to the physician to waiver that second OVA request will be in the bill this year. 24 patients completed their second OVA request. Next slide. And then in terms of prescriptions from us, you can see I have the data for all the past 3 years and years to date right now. 11 on Oahu, 4 in Kauai, and 2 in Maui. And then of those patients, 11 have ingested the medication expired. And most recently, in 2019, we did use D-DMP2, and most recently, D-DMA compounded medication. And the patients who were unable to is because they rapidly declined quickly, was a majority. And 1 patient is still alive with her prescription and doing okay. Next slide. I'm just going to run through this. The biggest thing is, once we started at Hawaii Pacific Health, we did work a lot with our leadership. We worked a lot with risk management. They were involved with me from the get-go with all the policies, with doing the marketing for the flyers. Once I tell my providers, hey, these people were involved, then they kind of feel relief that that was in place. Again, shout out to Dr. Miller. We're helping our oncologists to get on board with this program, and thanks to him, the oncologists have been fabulous in making this option available for their patients. And I already told you about the palliative care, etc. Next slide. Today, we still have less than 20 people who's providers who really want to participate in the law, but I can thank our oncology social workers, our nurse navigators, in providing that support. We back each other up. If I'm on vacation, they're on vacation, there's always somebody to help our providers, because it's very important. Their role is very important in this process. Education, I am just happy to provide education to our independent physicians. Our Maui, we had an independent Maui physician who, not part of HPH, but she had nobody to go to. And she reached out to her other colleagues in Maui and was met with barriers of nobody wanted to have that discussion or help her. And so she reached out to one of our oncologists who saw that patient a couple years ago and said, hey, I need help. And then that oncologist referred her to me, and I was able to help her provide her education. Says, yes, I will absolutely help you. We worked with Hospice Maui, and that nurse was the first time doing it. And as a team, we were a team together, and we did it where that patient was able to receive the medication. So shout out to people who are willing to help above and beyond their 4 walls of the clinic, because that's who we are. You know, Kaiser, Queens, independent physicians. It's okay for big organizations to have that support, but that physician by themselves, that independent practice, needs that support and help and guidance. And we're here to support them as well, because in the long run, it's the best thing to do for our patients if they want to proceed with this. And we already talked about telehealth and stuff. This is just a quick workflow that we have in our computer. Our staff loves it. They forget the process. Our doctors love it. They're like, where am I in this process? They can go into any of that part. They open it. They link that little box. They'll open it. And what they open is just the reminders of what has to be done, as well as all the links to the Department of Health forms. Next slide. Back to Dr. Miller. Thank you.
Thank you so much, Michelle. Dr. Miller, you're on mute.
Come on, there. Okay, I'm going to go quickly through this stuff. I know we're running out of time. This is the most current update as of December 31st. I can tell you just January and February, we have had 12 more referrals. And let's go down, look down at the 16 patients who died in a 20-day window. In the last month and 4 days, we've had 5 more patients die in that 20-day window. This shouldn't happen, and it's a real problem that I hope the legislature makes the appropriate changes, because, as I said earlier, it's usually pretty clear when I first see the patient, either by phone or by medical record or by telephone or telehealth, that you're not going to make 20 days. And I don't ever tell that to the patient, but I feel badly about it. So we need that change in law. Just skip the next slide and go to Brian.
Dr. Goodyear, are you there?
Yeah, thanks, Chuck. These are my numbers, and these numbers are actually up to date as of January 31st this year. I've performed 50 mental health evaluations since the law went into effect. Of those, 48 patients have been found capable, and only 2 of my patients have not been capable. And I think if you look at the Kaiser figures, as of the end of January, we're approaching 100 referrals total, and only 2 or 3 of that 100 have been incapable. So the lesson that I draw from that is that very small percentage of patients are not capable. And it raises the question in my mind as to whether a mental health consultation should be mandatory. I'm inclined to think that it's not really necessary, but that's something that needs to be looked at in the future. Okay, thanks.
Thanks, Dr. Goodyear. Unfortunately, Jake had to go because work called. So we're going to skip this slide and go to the next one. Why are patients using medical aid and dying? Just very briefly, Dr. Miller.
Okay. You see those the little squares there, and what patients who use aid and dying fear, they don't fear death. What they do fear is terminal suffering. Terminal suffering can be physical pain, psychological, could be social, and can be spiritual. And usually it's a combination of those various aspects of suffering. And my experience has shown me that the patients who choose aid and dying, they are very thoughtful, they're very courageous, they are insightful. They know why they want to use medical aid and dying. And that's why we're doing all this stuff. So
thank you, Dr. Miller. We're going to skip ahead to this slide because you actually already spoke about what the other slides talked about.
Okay. You know, the law does not require, if you as a provider, if you don't believe in aid and dying, you think it is inappropriate, is whatever you think, that's fine and that's appropriate. The law, unfortunately, does not require you to refer that patient to a provider who will take on medical aid and dying. But my feeling very strongly is that healthcare providers should have a professional integrity that requires them to refer a patient if they can't provide the care. And that's probably enough to be said.
Thanks, Dr. Miller. We're almost to Q&A. Just very quickly, we encourage you to go to our website, compassionandchoices.org. And in fact, I would encourage you to go to compassionandchoices.org/Hawaii. On our website, we have videos for doctors, patients, clinical criteria, all kinds of stuff. We have a free confidential consultation you can call 1-800-247-7421, and you can talk to another doctor free of charge. And I would guess most people here today would be happy to mentor you and help you, because like Michelle said, everybody on today's webinar goes way above and beyond, and we're so grateful for all of you. So with that, let's go ahead and go to the questions. The first question we have: why do so many patients die during the waiting period? That's an excellent question. And I'll start and then I'll hand it over to Dr. Miller. But I think, a lot of patients don't realize this is an option, and they don't realize how long it takes to get through the process. And I know some patients, when they're initially diagnosed with that terminal prognosis and their prognosis, they want to know all of their options, including end of life options. And I would encourage everyone to just make sure that your patient's fully informed about the different options and the fact that it really takes a while to get through this process, so that they start it early. I myself already know my doctor will support me should I get sick in medical aid and dying, because I don't want to have to search for a doctor if I become terminally ill. So, I know all of us have doctors or nurse practitioners, so talk to them early if you think this is something you may want. Do you want to add something, Dr. Miller, or anyone else?
The only thing I would add is that these patients wait too long. And it's not necessarily always their fault. It's a lack of knowledge and understanding of the law.
Yeah, thank you, Dr. Miller. The next question: is it legal to mail controlled substances such as diazepam and morphine federally and or state? I can speak to the state regulations. It is possible to mail aid in dying medication within the state of Hawaii. So that is an option in Hawaii. The next question, this was not clear during the presentation, but who does the patient have to make their first oral request to? So just as a reminder, the way the law works is you're supposed to make 2 oral requests to the physician who, in the law, it's called the attending physician. And this is the prescribing physician. Hopefully we'll be able to include APRN soon. But it's really important that, that request, it's supposed to go to the same physician, although they can transfer the first oral request to another physician, so you don't have to start the clock over on the waiting period if necessary. The next question is for you, Dr. Miller. What are the options if it becomes evident that the patient will not survive the 20-day waiting period?
Right now, there is no option. I mean, the law specifically states you've got to wait 20 days before you can write that prescription.
Thank you, Dr. Miller. I think, we just had a patient who reached out to us because he really wanted the option. His doctor wouldn't support him, and he wasn't able to make it through the 20 days, and he ended up choosing palliative sedation, which was not what he wanted. He really wanted aid in dying medication so he could be lucid and go on his own terms, but unfortunately, he just didn't have the time for that. So you could talk to your doctor about other end-of-life options if you're not able to access medical aid in dying. Another question: how are the different hospices addressing a patient's request for medical aid in dying? Are they supportive? That's a great question. Each hospice is different, so it's really important to understand what the hospice's policies are. The questions we ask hospices are: 1, are the doctors with your hospice, are they allowed to act as the attending and consulting provider? And 2, is staff allowed to be present when the patient takes their medication? And we really, really encourage hospices to allow their staff to be present. There is no reason under the sun why they can't be there if the family wants them to. In over 20 years, like I said before, there's never been a single incident of coercion or abuse. This is why we have the law. So each hospice is different. I will say it's taken hospices a little while to get on board. It's been hard for them, but I think they're coming around. Again, just interview your hospices, call them up and see if they will support you in the option. Does anybody want to add any final thoughts? We have 1 minute left.
Regarding the hospices, I would say some are willing to be the consulting physician, but none of them are willing right now, as of today, to be attending physicians. But regardless if they allow their staff to be present or not at the patient's bedside, full support. They're like right outside their premises as needed for the patient. Kudos to them.
Thank you so much, Michelle. Thank you to everyone who attended today. We are so grateful for all of our presenters. Mahalo and have a wonderful day. Thank you, everybody. Aloha.